Anamtua from Digital Square, and I'll be your moderator for today's session. So we're delighted to have you all here with us, and we appreciate you taking your time out to join us. So before we dive into our exciting agenda, I would like to welcome USAID for the opening remarks, then followed by Mrs. Zainab Sengeri from the Ministry of Health ICT for the opening remarks. So welcome, colleague from USAID, from the opening remarks.
For
Makunda.
the betas, yani targets we have currently on around 100%. And we have identified a number of cases around 77%.
Okay. Makunda. Okay, I guess we can just proceed, then he'll provide remarks later on. So without further ado, I just wanted to let you know that this webinar is recorded, and we'll provide the recordings after the end of this session. So I would like to welcome Zainab for the opening remarks. Karibu, Zainab.
Asante Anna, can everyone hear me? Wasemaji watakompensate kwenye hii ya Jumamosi ambayo inakamilisha yote. Hello everyone.
We can hear you, Zainab.
Okay, thank you Anna for this opportunity to provide the opening remarks from Ministry of Health on behalf of Director of ICT, Ministry of Health. I would like to welcome all of you to participate in this webinar as it is entitled for the best practice of deployment and training. So we hope you will hear much from our partners on how they do the processes of the deployment of the training process based on the practice they do in their field areas. So I would like to hear any contribution that will continue make this practice best due to how we practice in different projects or program areas. So once again, welcome all of you to provide your valuable support and contribution. Welcome.
Thank you, Zainab. So the main objective of this webinar is to share with the team on how best and the recommended best practices for deploying UCS. So we'll go straight to the presentation slide. And so I would like to welcome our first presenter, Mrs. Zainab, to take us through. So Zainab, welcome.
Hazina sauce.
Hazina sauce.
Thank you once again, Anna.
Nini huyu? Hamna tuta.
As I'm going to
Hamna register wala nini wala saba.
can I proceed?
Yes, sure.
So, and the aim of this webinar is to share with our colleagues who we are working in implementing the digital strategies on improving health services and continuum of care for our clients from the community level to the facility level. So I will shortly present how best we have implemented based on the requirements and training. As I'm going to provide this overview generally for the unified community system, how does it contain, what components are contained in the UCS and how did it come? So UCS is a comprehensive digital system that cover integrated community health services offered by the community health workers, HEW. It provides the community linkage with the health facility. It also contains both language, English and Swahili, so as to make it user-friendly for all HEWs. It contains of 3 components as Wadia application, Kituoni application, and dashboard. And soon we will have additional component which is ADO. It is not included in here since it is not completed. It is in the process of integration. So for Wadia application, it is basically used in the community by CHW, and Kituoni it is used at the facility level for those facilities which does not use any EMR. So this is a temporary solution as we need to make sure there is a continuum of care for the client from the community level to the facility. So we introduce the Kituoni application to cater that gap that will help us to see the trend of the service provided to the client. So once the facility has their own EMRs, Kituoni app will be phased out. So people might have asking themselves why Kituoni app. This is why we came up with Kituoni application. And we also have reporting dashboard, which is used beyond facility and community setting to support M&E planning and decision making. We all know that in any places that we collect data, we will need to use them so as to benefit for us to help us in decision making and planning. So those are the component of Wadia. As we see, this is how Wadia application can be seen and Kituoni application. Okay. Wadia application, as you see, so when someone is logged in, we'll be able to see the all client to register and all the programs that have been included within UCS. As we see, we have these modules and Kituoni the same. We have them under Wadia. Okay, the third component, we saw it is dashboard for reporting purpose. As we see, we have different data reported for the decision and planning. So all the modules that are within Kituoni and Wadia application, all the data will be displayed based on the indicators that have been selected in the program area. As we see, we have general, we have CBSH, C-level delivery. Those are the modules that have been created within UCS, and so we have to use the data within the application. And the data we get them from the data. So unified community system has been deployed at nearly national scale currently available in 24 of 30 regions in Tanzania, deployed in mainland Tanzania across 170 district councils, deployed in more than 1,700 facilities. Also built on the this application is built on the open source smart registry current version, which is the current version of used to develop UCS is OpenSRP 1. We all know that there is a second version which used it far, but it is not the one used. Status of UCS features as far as roadmap is concerned. These are the all modules that are developing within UCS. Other modules are under development. Others are in pipeline to be developed, and others are completed, waiting to be deployed. So we have UCS module for HIV, RSV, OVC, malaria, tuberculosis, and other cross-cutting modules. We have family planning, abortion. So UCS contain different modules based on problematic area. So this is how we can describe UCS based on the module that have been developed under UCS. I would like to invite other colleague to proceed with the presentation as far as my part is finished, or else if someone have any question that needs to be clarified, we're there to. Okay, so I forgot that I also need to present stakeholders. Who are UCS stakeholders?
Zainab, we can barely hear
So
you.
we have different.
There are a lot of background noises where you are. If you can move, please.
Sorry, because of circumstances and the area that I'm in. I'm sorry for that inconvenience. Let me look at this is the area that I find.
We can't hear anything.
Is she muted?
Hello. Okay, I think we can proceed with the other presenter who can take over Zainab's area. So I would like to welcome Julius Mahund from Afya Yangu Northern to proceed. Karibu, Julius.
Yeah, thank you, Anna, and good afternoon and good morning, everyone, depending on the time zone you are following this webinar from.
Hello.
Yes, can you hear me?
Can you hear me now?
Oh, Zainab is back. So Zainab, please go ahead.
Sorry for the inconvenience. So I was about to finalize the last slide for what I have to present, which concern different stakeholders level based on the UCS implementation. So we have different levels from national, regional, facility, and community, and where these UCS have been used. So the system will have level and system users. The system users from national level are Ministry of Health, Office, PRLG, donors, and implementing partners. This is from the national level, which is the highest level. Regional and council, we have users from regional health management team and council health management team. We also have facility level, which we have main users who are health care providers. And lastly, we have community, on which we have community health workers, mother champion, and COPS.
We can see here we term CHW, but different program use different word to mark CHW. As for malaria, they use COPS. We also have Mother Champion for HIV and community healthcare workers for the general services provided at the community level. So these are the different levels on where community system is being used and who and system users. I think this marks the end of my presentation.
Thank you, Zainab. I think we can proceed with the other area, and for the questions, they can be provided in the chat, and also at the end of the session, we'll have the question and answer session for everyone who has any concerns. So, welcome the next presenter.
Thank you again, Anna. So I'll already introduce myself and I'll take you through a few slides. And before I speak about the best practices, especially on UCS training, I would like to highlight on how UCS support community health intervention and specifically the continuum of care in the community health. Next slide. Yeah, so from this slide, you can see that UCS has facilitated seamlessly flows from community to the facility, and they're impacting more than 50,000 referrals being sent to health facilities, out of which 14,000 have been completed. And this ensures there's greater chances for clients to obtain appropriate care and follow-up in the community. The referral completion, you can see, is low, and this is especially during the pilot stage where there were issues around internet connectivity and availability in some places, which impacted, the low completion rate of referrals that you see from the slide. But also, UCS has strengthened the implementation of both community and health facilities by ensuring there is always timely data collection and reporting, but also on how UCS, is improving the referral system and making sure that more people have access to service delivery. As we speak, more than 700-800 clients have been reached. 1,000 clients have been registered in the UCS, and they benefit from a number of services, from HIV to maternal health to malaria, community-based health services, and the like. But also, UCS has fostered, the integration of services. So healthcare providers are able to, provide a holistic care to our patients, and therefore being able to see their health needs, their history, and therefore providing more coordinated and effective care to our clients. UCS has, been able to improve, the timeliness of care, but also the accuracy of how, services are being provided to clients, because UCS is developed in a way that it is a decision support system. It's not only a data entry platform. It's there to guide healthcare providers on which services to provide to which clients at which time, and therefore improving also the monitoring and surveillance of services. You can see the malaria modules coming in, but also they are being able to provide equitable access to healthcare. Next slide. So this is also in terms of continuum of care. And from this slide, it's just the number of clients that have been enrolled into community-based health services by community health workers. So more than 68,000 clients enrolled, and they've been visited more than 87,000 times in their homes. And therefore, when they visit, and these clients are those PHIV, TB patient, pregnant women, under 5 children, and those clients that have experienced gender-based violence. So they're being visited in their homes and being provided with a number of services, including screening for danger signs, counseling, and referrals to health facilities for services not provided by healthcare providers. Next slide. So here I'll speak just for a few minutes about the best practice in terms of UCS training preparation. What are the things that we need to take into consideration, especially for our partners? More partners that are coming in, they want to start training for new modules. So next slide, we'll talk more about what are the things to consider. Next slide. So the first thing that we saw as the best practice was, adoption of a classroom-based approach. This was a good approach that we saw giving us good results in terms of training. We kept our classes as small as possible, with a recommended of a number of 50 participants per class, and therefore making it manageable by trainers to do facilitation. And the organization of classes, were based on, the roles of the system users. So healthcare providers and community health workers were kept in separate training rooms to allow them to be able to navigate, the systems more efficiently. But also we coordinated so well with the government in terms of the training structure, in terms of the training schedule. The government from national level to the regional and council level, to the facility level, in terms of where the training is going to be conducted, when is it going to be conducted, for how long is it going to be conducted. So they recommended a number of days by the Ministry of Health were 5 days of training. And this was an evidence-based model to share adequate skills and knowledge to system users. But also we ensured that there was an adequate tablet or other devices for participants for training. And why this? This is because the UCS training is designed to be very practical, ensuring the participants have time to interact with the system, learn the skills and practice with a lot of scenarios for them to be able to use the system immediately as they complete the training. And the other thing is preparations in terms of configuration of devices. And this was to be done prior to the training to ensure that the devices are ready for being used during the training, to avoid all inconveniences that might happen, and losing more time for training. And this was even done as early as 2 weeks before, and this was going hand in hand with requesting for user credentials for testing during training from the Ministry of Health. But also, we had a well-prepared training materials available, and these materials, from the training materials for participants to facilitators guides and preparation for different user scenarios in order to facilitate a smooth delivery of programs. So this was very good, and the facilitators had to distribute some user guides to participants, which can be used as reference during training. And the last point was a stable internet connection. This is very, very important for anyone who needs to do a successful training for users, because there will be a lot of training sessions that are practical, that referrals will need to be sent from health care providers to community and back to healthcare providers for facilitating the bidirectional referral for them to be able to learn and practice the sessions. So this was also something that is very, very important. Next slide. Yeah, so this is now the training itself. Here, we need to ensure, the trainer allocation. And I said before, in a class of 50 participants, the recommendation was to have at least 3 trainers who are there to impart knowledge to participants that can be able to supervise the training, especially the practical sessions, but also to provide any technical assistance that is needed. A lot of our users, especially community health workers, they are laymen when it comes to technology. So not only navigating the device, but also the system itself needed a lot of technical assistance. But also employ some different delivery models in terms of training. So our training, was a combination of both theory and practical training, ensuring that our participants and users, were able to navigate the system, interact with it, and then being able to understand it fully. But also testing of knowledge before and after. So there were pre and post test assessment to know how much knowledge have they gained in terms of as far as the training is concerned. But immediate follow-up was also very key in terms of ensuring that they don't forget what they have gained from the training. After the training, the team would, coupled by partners and UCS facilitators, would go and offer support in the facilities and communities as needed. And this was also informed by the tests that were conducted, both the pre and post-test training, to ensure those with low, understanding would receive immediate post-training follow-up. And the last, in terms of training, was to be able to identify champions from those very sharp and quick learners in the group, and ensure that we utilize their expertise, and their readiness to system adoption, to make sure that they provide a culture for continuous learning and improvement, but they're also engines for UCS sustainability. So this is my last slides, and my colleague will now talk about the post-training. Thank you, Anna.
Thank you. So I'd like to welcome the next presenter, who is Maiga Msliba, community healthcare worker, so that he can also present and demonstrate on his experience. Welcome, Maiga. Hello. Okay, so I think I can.
Hello.
Hello?
Hello. Yeah, okay.
Yes, we can hear you.
Thank you. Do you hear me?
Yes.
Hello.
We can hear you.
Good. Okay, thank you. So I would thank you for this opportunity, and good evening. So for the thing that I want to share with you, or to talk with you, is deployment model. As community health worker, as UCS, help us to simplify some work of register, some clients, and a lot of things that help us to simplify a lot of work. But when I go directly to the thing that I need to talk here, plan for immediate deployment post training. As we know, before the intervention of UCS, we used it to records or to put some our data through writing papers, but there are some challenges that occurs when we use such kind of maybe such kind of hello.
Can hear you very well.
Can hear you.
Can you proceed?
We can hear me? Okay. When I talk about planning for immediate deployment post training, so as we see here, provider tends to forget what they have learned if there is significant gap between training and deployment timelines. Therefore, it is recommended to deploy the UCS immediately after training to ensure knowledge retention and practical application. So when we go direct here, before the intervention of UCS, we used it to records or to put our data through paper records. That leads us to get some challenges. Some of data were stolen, were missing. So after invention of UCS, help us or simplify to do our work very shortly, and also it help us to use some short time to put the data through the UCS, and also UCS after gets the training through UCS, we I want to say that hello. I want to say that after intervention of UCS, and to simplify our work so that the records that we put through UCS, sometimes you get, or you if you want the information, or if you want the data quickly about the client when about the client when the client reach at the facility, it make it very easier to check the information about the client. But when we go, I think point number 2, include preparation at the governance level. Involve regional RHMT and council CHMT leaders in UCS implementation to ensure ownership and support at the local level. Equip them with the necessary credential and support to manage and follow up on UCS implementation effectively. When the UCS introduced and after the training, we start to use the UCS, there are some challenges where we were facing for that period, but through this team, RHMT and CHMT, they create some thing like a supervision in order when we already get the training, but it's not end when we get the training, but there are some we were needed the supervision or to supervising us when we facing some problems when we enter the records through the UCS. some of us we're facing some problems when there are someone you may found that maybe he put data for some mistakes. So through CHMT and RHMT and CHMTs, they help us to supervising us and to guide us when we're facing some problems. So they use that to come to us and to direct us when we're facing some problems. And if we maybe some may found enter the data incorrect, they guide us how to manage data, how to record data, and also they supervise us to maybe the data to share somewhere if there is something maybe want to see how the UCS training is outcome of the outcomes of US training after we get the training. So the point number 3 here, map mobile or internet services providers. Identify and map mobile service providers based on strengths and the weaknesses of each provider in specific areas. This ensures uninterrupted internet connectivity for facilities using the UCS system. About this, stakeholder EGPAF, after providing this, maybe tablets, and after we finish the training about UCS, they provide some tablets in all facilities, but they not end up there, but they also provide some chip. We use mostly Vodacom internet, but when we use some Vodacom internet, some of us we were facing internet problems, but we already when we facing that problems, we communicate with supervisor who used it to supervising us when we're facing problems, when he want to maybe to enter in the UCS and he look when the facility the trend of facility to register the client through UCS. So when we continue using UCS, they provide us routers, but we use also Vodacom internet. But when they provide routers, when they provide you routers, in order to use that to connect, maybe to connect it when we want to sync data, it also help to simplify the way that we put the data in the UCS. I think I understood. Hello. Okay, I'll continue. Develop a phased deployment approach. Implement and phase the approach for UCS deployment and gradually expand based on effective utilization and availability of resources. This approach facilitates smooth training and support. Also, when we already get some training through UCS, for my experience, when I'm continue to using tablets to enter the data or to register data, it simplify our works very smooth, because when we use UCS to enter the data, it simplify us when we have a lot of work. So it takes a lot. It takes short time to enter the data rather than when we using paper data. I mean paper records. And the practice continuous monitoring and evaluation. Conduct regular internal meeting to track progress and assess indicators to ensure effective deployment. Implementing partners, emphasizing the importance of monitoring UCS progress and addressing user issue promptly. As I speak earlier that CHMT, RHMT, together with stakeholders, when we already get some training, they not end up there, but they trying to supervising us when we facing some problems, in order to make sure that the training that they were provided for us make some positive make some make some positive results. So they monitoring and evaluate when they monitoring and evaluate for the time when we start to using when we start to using this when we start to using this maybe I mean this program, and when we continue they also they also monitoring us when we get some any problems, and also they create some they create some something like when after maybe every week there are some reports we supposed to there are some reports they support we supposed to prepare and to send. So that reports we write down as a paper records, and they compare to the system and the paper records that the report that we prepared and send it to the supervisor. Provide system management and support. Continuously engage the council health management team and the regional health management teams. Emphasize the use of help desks and facilitate communication through WhatsApp groups as essential ways to report system issue encountered while using UCS for technical support and effective management. As we speak, when the UCS in when the UCS start when we start to using UCS, they create some WhatsApp groups that help us when we facing some problems, in order to help us when we facing some problems, so that to so that to 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 simplify when we get some problem. So they create some groups that we share some problems, or we share something that we facing when we using the system, in order to make us that in order to simplify the work that they already gave us as a training. So for me, I want to say that the UCS the intervention of UCS help us to simplify the facility activities as we use in the CTCs, RCH, and also to document some of our clients, and also to make a follow-up to our client through using UCS rather than using paper records. Thank you.
Thank you. I
Yes.
think we'll wind up with the last slide, then with the question and answers. So I would like to welcome Dr. Patrick or Dr. Onesmo, so that they can share their experience on how the best practices have enabled them in the rolling out of the UCS ICCM module. Karibu. Dr. Onesmo or Dr. Patrick? Okay. In the course of time, I think we can just proceed with the question and yeah, recommendation. So I would welcome anyone who has any questions.
There are questions on the chat, I think.
Okay, let me read them. So we have the first question from Mashahuri. It says EMR in Tanzania is quite a contradiction and tiresome integration is the key for all of this. Imagine health workers has Mtua, books, Homies, and UCS. How can he or she concentrate in all those areas? Single is EMR is what is required to simplify all this. Fragmentation has no role at all. So UCS for the UCS has three components. So there is the one that is used at the facilities, as there is the other one that is used at the community level, so that it can bridge the gap between the services at facilities and communities. So UCS at the community, which is the Kituoni component, is only being used if the EMRs are not there. So with the existence of the GoTHOMIS, which is the EMR at the facilities, at most of the facilities, so it would also enable the continuity of the health care from the health facility to community. So I do concur with you with the recommendation that the integration between the EMR as well as with the community system to avoid the fragmentations of these. So that point is also taken. There is the other from Abba is, greetings everyone, is UCS only available in Tanzania or can I access on Google Play? So currently UCS is implemented in Tanzania and it's accessible, yes, in the Google Play, but however, you would also need credentials from the ministry, request the credentials from the Tanzanian ministry for you to also attain. So however, it's being built on the OpenSRP platform. So we can also discuss on how best you'd also want to implement it on your country as well. Then Bakari, tablets or smartphones can be used on UCS. Yes, I guess yes, tablets and smartphones can be installed in UCS. So the other one is from Alphonse. Okay, great. So I'll go to other questions below. Are there thoughts or plans to expand UCS to Zanzibar? With this, I think UCS has been used in some areas in Zanzibar, but also with the collaboration from the ministry, Zanzibar ministry, I believe we can also look of ways to expand this as well. Does the system allow to export client level data, example names for future analysis? So UCS has reports that at facility level or community level in which these reports can be exported and analyzed for further decision making, but also the national central dashboard for the UCS system, which it contains aggregate data that can be used for decision making. So let's see. So I think in the essence of time, these recordings will also be shared to everyone, but also you can provide us your recommendations through the emails that you have received the recording. And to wind up, since we did not have Patrick or Dr. Onesmo present us to the impact of these best practices, I'll just provide a highlight. So these best practices we're able to assist for the sustainability purposes in case anyone wants to roll out UCS at their facilities or selected regions or country. Most of the time you wonder what should I do, where should I start? So these practices helps and guides the stakeholders, either the government or the partners, on the deployment of the UCS, as we have all been able to see what are the prerequisite requirements that you need to deploy, and so that you can start preparing. And when you go to the training or conduct training, you also need to know what are the things that one must have so that they can also have and conduct effective training as well. And for the deployment, also to have a successful deployment in the selected locations, you would also need to know what approach are you using. Is it the direct approach? Is it the phased approach? So we're able to provide the recommendations based on experiences from stakeholders who have already been using or who have already rolled out UCS in their facility. So I believe and I hope this webinar was able to share that highlight and be insightful for everyone in this meeting. So also I would like to welcome Makunda or anyone from USAID for the closing remark. Karibu.
Thank you very much, Anna, for organizing this webinar and putting together the slides. Yeah, so from USAID, we are saying thank you very much for Path Digital Square, both the Dar es Salaam team and also the Seattle team. Number two, from the Ministry of Health, PRAG, and also several vertical programs, colleagues who are here today, thank you for your leadership and coordination as we are all working together to push forward the agenda of the unified community system, which is part and parcel of the Tanzania Digital Health Strategy, but also implementation roadmap. So we are keenly to continue working with all of you to ensure that we arrive into the destination that we are all looking forward to. Why USAID Tanzania, in collaboration with our colleague from DC, we are funding this initiative through our implementing partners. One, we want to ensure that we are empowering the community itself. How? We want to ensure that we are empowering them to take active role in managing the health of the people or clients and patients that we serve at the community, but also to the facilities around their localities. Again, we know that it's very important for us to working to improving the health outcome. And how do we achieve that? We know that, as we have seen from the presenters, the number of the people who have been registered in different services, there are around 800,000 individuals. And those are not numbers, but people on the systems. So UCS is providing them with reliable data for them to be able to address very specific health challenges that the community is facing. And those are from the malaria, RMNCH, family planning, HIV, et cetera, et cetera. At the same time, we know that by funding our implementing partner, we'll be strengthening the digital health infrastructure. For instance, we have seen the number of CHW and the CBHS that have been trained on this intervention. And I was very happy to hear one of the CSW presenting today as an evidentiary value that it demonstrates the ownership of this system. But again, we're about to hear something from the malaria component of the UCS in terms of how are we enhancing the disease surveillance in terms of the early detection, but also improve the data accuracy. So we are committed to continue working with the government of Tanzania and all the vertical program to ensure UCS is helping to transform the health outcome of the people that we serve. We're not doing this alone. We have our team from DC. William is here today. Joy is here today. We have our governance meeting every other week to ensure that we all work together to push this agenda forward. So with those few remarks, Anna, I'll take it back to you. Thanks.
Thank you, Makunda. So with that said, this meeting has been closed, and thank you everyone for joining, and goodbye.
Bye. The recording. The recording, please.